Hi, so thank you all for joining us in Workshop B, where we will be addressing climate-mediated disease in the clinical setting. My name is Alison Lee. I am a pulmonary and critical care physician at Mount Sinai in the Department of Medicine with a secondary appointment in the Department of Pediatrics. And my research largely focuses on the role of air pollution exposures over the life course in increasing risk for chronic disease. Perry?
Good morning, everybody. Perry Sheffield. I'm a pediatrician, also based at Mount Sinai. I work in environmental pediatrics with our New York State Children's Environmental Health Centers and our Pediatric Environmental Health Specialty Unit, which is part of a national network. My research focuses on climate-related health effects with emphasis particularly on children. So we want to know a little bit about who's with us, but understanding that it's a robust group and growing, and we have short time. We invite you to put your name and who you are in the chat. We'd love to know whether or not you are a clinician or not, and so that we have a sense of who's here today. And in the interest of time, while you are working on those introductions yourself, I'll turn it back over to Alison.
Great, thank you. So we have heard a lot today about how climate change affects air quality, particularly by increasing air pollutants, fine particulate matter, which is PM 2.5, ozone, and also via effects through allergens such as pollen and mold. And clearly, as demonstrated by speakers earlier today, there are numerous health effects really that affect every organ system and therefore affect every type of clinician with regards to patient health. And we think it is critical that clinicians and others in patient interactions are able to understand how climate change may be affecting your patient's health individually, and helping your patient understand how they can improve their health via potentially modifying exposures. Next slide. So just a brief overview again, a lot of these points I think were addressed earlier. Specifically with regards to ozone, we know that pollutants have both short-term or acute effects and long-term and chronic effects. In terms of short-term ozone exposure, there is evidence that this leads to increased airway reactivity, impairments in lung function, and of course, impairments in lung function in childhood lead to poor lung development and increase the risk for poor pulmonary health in adulthood. What you can see here at the bottom right is a figure that was published in an EPA publication, but essentially it shows that short-term ozone exposure is also associated with the number of emergency or urgent daily respiratory admissions to acute care hospitals. And so this graph represents data from 168 hospitals in Canada over a 5-year period. And on the x-axis, you can see the daily 1-hour maximum ozone concentration, which is like by 1 day. And the y-axis is admission rates. And essentially what you can see is that there's a strong relationship between the two, suggesting that on days where there's higher ozone exposures, there's increased in respiratory-related hospital admissions or visits. Clearly, in the long term, all of these effects together can lead to lung scarring, permanent reductions in lung function, and increased susceptibility to infection. Next slide. We've also heard today how climate change can affect free season length, which is defined as the period between the last occurrence of 32 degrees Fahrenheit in the spring and the first occurrence of 32 degrees Fahrenheit in the fall, has increased steadily in the United States. And increases in the frost-free season length correspond to similar increases in growing season length. And so therefore, allergy season comes earlier, is longer, and is more intense. And of course, when we have more rain, this can lead to more mold in the environment. What you see in the figure on the right is the relationship between CO2 production, which is listed annually on the x-axis and by the bar graph there, in relationship to ragweed production, essentially showing that there is a strong relationship between these two, and that in a CO2-rich environment, plants may be more robust and produce more pollen, and that pollen, in fact, may actually be more allergenic. Next slide. PM 2.5, or fine particulate matter, is a very important pollutant, and it really is it's the size of particulate matter that is able to move distally in the lungs, reach the alveoli, and actually cross the alveolar blood barrier. And fine particulate air pollution comes from many sources, including power plants, industrial processes, vehicle tailpipes, wood stoves, and wildfires. Next slide. We know, again, of PM 2.5 exposure on health outcomes. And you can see that here represented in the figure. We've heard earlier today that short-term PM 2.5 exposure is associated with hospitalizations, ER visits, medication use, asthma exacerbations, and that long-term PM 2.5 exposure is associated with cardiopulmonary mortality and all-cause mortality. Next slide.
So you also heard, if you were part of the earlier sessions, about heat and heat health risks. And I'm not going to go into a lot of detail here, but I just want to reorient us as we go into our case scenarios in just a minute. And heat risks can be in urban settings, they can be in occupational settings, they can be in sports settings, anywhere that people are exposed to high ambient outdoor temperatures, and particularly if they are doing things with high exertion or with extra coverings, reduced ability to dissipate their heat. And we talked earlier about the iceberg analogy. Here I'm using a pyramid analogy to talk about probably what is a much underestimated burden of heat-related illness on our population, from my angle, particularly on children, but probably on multiple age groups across the life spectrum. We hear most about the deaths, and we actually probably hear less about heat-related deaths than some of the more dramatic or obvious ones. Heat is an insidious risk, and often leads to underestimating our risk to our understanding of risk to ourselves or to our loved ones. But we know, we're increasingly understanding that heat has many effects that are less visible and probably more widespread. And so Dr. Salas gave an example of heat potentially affecting the antibiotic resistance. So medications, which are used to fight infections, right? If they are increasing the rate in which microbes are developing resistance, then that is going to have insidious effects somewhere in the middle of this pyramid. Somewhere down near the base might be the things that are often thought of as outside of the healthcare realm, for example, learning. But we know that learning and school success have profound effects on health outcomes in the long run. And so as we're coming to understand that high temperatures in unair conditioned classrooms can affect test scores, graduation rates, learning, those are important outcomes as well to think about. And then the last point I want to make in this brief sort of thinking about heat and thinking about this background is that some of the solutions are eloquent and simple. This is a shading feature that's used on a playground in Manhattan, and it's beautiful, right? And it probably increases the safety of this playground on hot days, its enjoyability, and thereby increases the likelihood that people are going to have more physical activity and do it safely, which is critical on many fronts. So just some key points about the heat health risk before we move on. We know that it's preventable for children during sports. We know that construction and other outdoor workers are at high risk of death, and that is increasing because of climate change. Something we're not going to delve into much today, but is an important heat health risk globally, particularly, is chronic kidney disease among workers in outdoor jobs. And we know that there's a number of exposures. Chronic heat exposure, usually we think of heat as sort of an acute risk, but we're actually learning that chronic heat exposures coupled with dehydration, the physical effort I mentioned, obesogenic diets, certain chemicals like certain metals or pesticides can all increase the risk of chronic kidney disease among workers. We know that all of those things I just mentioned disproportionately can impact Black and Brown and low-income communities, whether or not that is because of increased risk through certain types of occupations or because of longer commute times on public transportation to jobs, or because of lower air conditioning prevalence and less ability to recover after exerting oneself, whether or not it's through a sporting event or something else. And we know that because of all this, school and workplace interventions with surveillance and improved regulations and enforcement are going to be necessary going forward. And then again, before we get into our clinical scenarios, we wanted to just touch on this idea of communication. Dr. Bernstein mentioned this article that just came out last month by Drs. Sinai, Safferty, and Rice, talking about how we talk about this, right? This is a national issue about how do we talk across politics and perceived differences of opinion. And one of the key messages here is we have a lot of common ground around health effects, right? And a desire to have healthy patients, healthy families, healthy communities. And one of the key messages from their article is that clinicians can really help counter misinformation. They use an analogy about a pre-inoculation to misinformation. It's kind of like a vaccine, but in terms of knowledge. During these routine visits, by using simple messages that educate and empower patients. And they give some patient-centered strategies. This goal is conveying medical information while addressing patient concerns and expectations. You have really focusing on that common ground to find a best path forward, acknowledging that clinicians play a critical role in this, and that physicians routinely counsel on drivers of disease and should also thus educate patients around these health-related risks, even on perceived controversial topics. And then lastly, it's important to explore the role that climate change plays in patients' health and ask permission to discuss these topics and resist the impulse as a clinician to convince or confirm, but confirm your respect for their views and conclude with again, with that commitment to their health. And the article that I'm mentioning has a nice table with some specific samples, but I also wanted to highlight this poster that is part of the poster presentation that you'll see in our video presentations just after this workshop. This one from Loyola University with one of our trainee, some submitters also give some very specific advice around certain things that can literally, in quotes, be said to patients around different health topics. So I just wanted to give them a shout out as well. Okay, I'm going to pass it back to Alison to launch into our clinical scenarios.
Thanks, and sort of scrolling through the chat right now, it does appear that we have sort of a range of backgrounds on the call, which is really exciting. We have a pathologist, we have pediatricians, adult physicians, emergency medicine physicians, and also non-clinical people as well. So, including students, we have some MPH students included in the group. So just a really exciting range of backgrounds. And please, as we're moving forward, it would be great to have this be as interactive and lively as possible. So please do feel free to unmute yourself to be involved in the conversation. It would be great perhaps to kind of try to break some ice if I could ask if there's anybody in the group that would like to read the first clinical scenario presented here. Just feel free to unmute yourself.
I'm going to ask.
Start. Go ahead.
Go ahead. Go ahead.
This is Matt Masiello. I could happily read the first case.
Great. Do you mind introducing yourself and your brief background? And
sure. Matt Masiello, pediatrician and clinical professor at UMass in Worcester, Massachusetts. Had the opportunity to participate in a Yale climate change course as an adaptation practitioner. And I attended your conference last year and it was great, and happy to be here this year.
Thank you. Thanks so much.
So I'll start. So little Mr. Macaulay here is an 11-year-old child with asthma. In a positive skin test dust mites. Now with exacerbation of symptoms requiring frequent bronchodilator, mostly while at school, and a few nocturnal episodes. He attends a new middle school close to an interstate undergoing construction to widen it and resulting in heavy trucks and machinery operating throughout the day.
Thanks so much. Next slide, Perry. So the first question for discussion is, what do you think is contributing to Macaulay's worsening asthma?
Oh, well, I'm still unmuted, so this is Matt again. I would say the exhaust from the heavy trucks passing by.
Right. So I think, especially for the clinicians in the room, we all know how important, especially for asthma, how important the sort of social exam is in terms of trying to understand potential exposures. And of course, in Macaulay's case, it looks like he is attending a new school. And that school is in very close proximity to a highway. And then, of course, the highway is undergoing construction as well. So next slide, Perry. So just key points here. We know that indoor pollution levels are related to outdoor pollution levels, and therefore, due to the proximity to this major roadway, it is likely that classroom air has been compromised by these outdoor air pollution sources. And we know that air pollution near these sites is going to be a mixture of gaseous pollutants, also of particle pollution, and mobile source related pollution as well. And there is significant literature suggesting that persons, particularly vulnerable communities, and so this can be children in schools as well, that live in very close proximity to highways, are more likely to use asthma medications and have cough or chronic and nocturnal cough. And so clearly we're seeing this here in Macaulay's case. Next slide. So what would you recommend to Macaulay's mother, who, after sort of diving into this, you're able to educate her on the importance of this exposure in terms of her son's asthma control? How could you educate and sort of offer some solutions when she tells you that she's unable to move her child to a different school that's further away from construction or further away from a major roadway? And if I could pick on some people in the room, I know we have a number of, for example, emergency room physicians and pediatricians, and I just wonder if this case is similar to others that you've seen, and if there are certain strategies that you've employed in the past that you could perhaps, suggest or to the group.
This is Stephanie. I'm a pediatrician, and I think you could start with sort of the basics, just ensuring that Macaulay is taking a controller while these exposures are ongoing, if not already, and then potentially have mom see if she can talk to the school about using an air filter, like an air purifier, in the classroom, seeing if mom is able to provide that in the home. And then maybe if there are certain times, if it's possible to modify like the times that Macaulay is traveling in the area where there's the most exhaust, to try to modify that as much as possible if there are certain times of day that area can be avoided. And then potentially just having her make that connection that is what is contributing to triggering. And so having, encouraging her to talk to other parents, talk to her, city representatives, talk to the school to ask them to use like not let the trucks idle during construction, or in other ways advocating for environmental improvements.
Yeah, those are great responses. Thank you so much. And I mean, it seems like you're sort of touching on two different themes. The first being that clearly there should be some changes to the medication regimen. So whether that's a step up in treatment, trying to sort of time dosage of medication perhaps around periods of increased exposure is hugely important. And then, the second piece, which has to do with education, is just to ensure that the mother is aware of these relationships between exposures and asthma exacerbations, because then I think, as you mentioned, then it sort of empowers or enables her to become an advocate for her child. And Perry, if you want to go to the next slide, I mean, I think that, items that you mentioned, so whether or not the school can put air purifiers in the classrooms. And actually, just to take a step back, the other point that you mentioned is that, the mother could also speak to other parents, because clearly if there's one child being affected, then there are multiple children being affected. And whether that's asthma exacerbation or whether that's just increasing risk for other diseases as well, we know that that's hugely important. So empowering the mother to become an advocate, to ask whether or not the school can do things such as, install air purifiers, changing the filters, speaking with the construction teams, et cetera. I think those are all hugely important points. Does anyone else have comments as well on that topic?
Yeah, this is Matt Masiello again. I would also offer that, many of these schools, there are school health councils and PTAs, and that parents should not feel alone in their quest to do this. And for the pediatricians, quite frankly, to make contact with the local public health department and even the schools, and even in any local pediatric group that may be part of that community, to bring up these topics and discuss these topics, to really see where those children are, and if there are any other if there is a disease prevalence difference between that particular school and any other schools in the area. That type of activity, certainly leads to potential increased funding and other supports for these parents and schools.
Thank you. That's
Thanks.
a very important point. Any other comments? Next slide, Perry. I think the other sort of important point is, I don't know how many of you are familiar with this case. There was definitely a lot of news surrounding this in December. It's a case of a young girl in the UK, Elo Kissa Deborah, who unfortunately passed away from an asthma exacerbation a number of years ago now, but recently her death certificate was changed and air pollution was listed as a cause of death. And in the media reports from this case, what I think is really important is that her mother says that she was unaware of this link between air pollution and asthma exacerbations. It wasn't until after her daughter passed away that she became aware of these associations. And in fact, to her, after she understood those associations, sort of the pattern of her daughter's exacerbations really became clear. And so again, I think that it's hugely important that we take every opportunity possible to educate our patients so that they can become advocates for their children. And clearly, I think that this is a good example of why that's hugely important.
This is Alyssa Gordon. I wanted to make a comment on the advocacy component. Hi, everyone. I'm a gastrointestinal pathologist. I'm also the medical director of our sustainability team here at the Cleveland Clinic. And I would say I've always been hesitant about advocacy because I think it means like going and testifying before Congress or going to, for us, Columbus, Ohio, and talking to legislators. But I really appreciated your example in this case of, encouraging the mother to be an advocate for her child by talking to just the local representatives in terms of this particular issue and bring it to their attention about the construction and idling of the trucks, and just like it seems like a little thing, but those things add up. And I like that perspective that advocacy doesn't have to mean writing op-eds and going to talk to people who make laws. So thanks for that.
Yeah, no, that's a great point, that that advocacy occurs on many different levels. And I think that especially for parents with a child who is suffering from repeated and worsening asthma exacerbations, there's clearly just a lot of motivation there, and I think that that it becomes incredibly powerful, even on sort of the school level, the classroom level, etc.
Can I just add to that? This is Matt Masiello again. The issue of city planning is key here. Also, you have to wonder why a new school was built in this particular environment. So at the other end of advocacy, it really is significant for us to make sure our local politicians and legislators and town supervisors are aware of the association between pollution, illness, and where they build their schools and businesses in any given community.
Yeah, thank you for that. And the EPA actually has voluntary school siting guidelines. They don't have teeth in the sense that it's not required, but there is guidance in terms of people who are looking for support in their advocacy efforts. If there's a school siting, if you have the opportunity to be more preventive about it, there are documents that can help support that effort. I'm going to go on to our next case, and I see that I would like the students to help me out with this one. could Isabel read the first 3 bullets of Anthony, 15-year-old student in suburban southern town? Isabel, are you there?
Hi, yes, I'm here.
Okay, and if there's for any of you, if there's medical abbreviations or whatever that don't make sense, then we'll fill in the blanks. Don't worry about it.
Okay. Anthony, a 15-year-old student in a suburban southern town, is a rising freshman with no significant PMH except summer flu during camp each year and prior fun runs with family, but new to cross-country team.
Great. Pranav.
Okay, first day of practice goes well. Temperatures in the high 80s. Second day, he joins returning runners on longer run. The temperature is 90 degrees Fahrenheit. During the last mile, he feels thirsty and very tired, does not recall the final approach to the school, nor crossing the busy road by school. Found weaving unsteadily, driven to the ER, vomits and makes incoherent statements.
Okay, pause right there. And Donald, are you able to unmute?
I am.
Can you read the last 3 bullets, please?
Sure thing. At the ED, Anthony is combative and rude. Pulse is 120 beats per minute. Temperature is 100 degrees Fahrenheit. His skin is warm and dry. No signs of trauma. He vomits again when oral rehydration is tried, and IV rehydration is tried as well. Diagnosis is heat exhaustion. Anthony returns to practice the following week, finishes the season, qualifies for the state championship. Wow, and leads his team in his last years of high school.
Yeah, so this is a scary case that has, in a sense, a happy outcome and no obvious long-term sequelae. But I think there's a lot of learning points from this. So I want to pose a question to you all. What in that history that we just read, did you feel like there were any factors that contributed to this, to Anthony experiencing this heat exhaustion event, like both in his prior medical history or in the preceding days or weeks? And Jennifer Lawson, I saw you contributing. Thank you by chat for the last. You're welcome to unmute anyone and speak or add into the chat.
Something that I'm Pranav, and I guess in addition to looking at sustainability in healthcare delivery, I manage the Half Pint Prairie restoration, and we promote green space in urban settings. So what kind of stood out in this scenario was he's from suburbs, and there's typically a lot of green space there, so they're not really subject to the same urban heat island effect. So he seems like he has plenty access to green space. So it's kind of interesting as to what would have put him at particular risk for this activity.
Great point. So he probably did have, his community probably had green space, this suburban area. Anybody have other ideas? This was the second day of practice.
I was thinking about just, pre-hydration, conditioning, but also was wondering about the surfaces. What kind of surface are they training on? Some of those athletic surfaces are so, well, cross country probably not so much. I feel like they're not on a track, but they're so heat absorptive.
Yeah, and a lot of cross-country teams go and run in some of the subdivisions surrounding the high schools on asphalt. So even though there is green space, they're on sort of the hottest spot of that suburban area. All right, so you named some of these. Let's see, what did we have on this list? It was warmer the second day. And it was the second day. So as Jennifer just mentioned, maybe the prehydration, or maybe he had less reserve than on that first day. He maybe came in slightly dehydrated. He had not, sometimes returning runners are invited to come back and run shorter distances for the preceding week. But as a freshman, he hadn't been part of that since he just walked onto the team. So the risk to athletes and the workers are of acute heat-related events are highest in those first few days. We know that epidemiologically as well. All right, so what could a health professional have learned from, presumably he had to get a pre-participation sports physical, or maybe just anticipating that this teenager was possibly going to be participating in high school sports, maybe offered his guidance to this patient and his family. Anybody have ideas about that? there was that little bit about summer flu in his history, which is probably not anything significant in terms of sort of day-to-day and life expectancy and all of that. But maybe something about this individual's susceptibility to dehydration in the past. Other ideas? Asking about the prior history, thank you. Or heat illness in family members, sure, yeah.
I can't add any medical knowledge necessarily, but at least from personal experience with sports, I'm from South Florida, so we have a lot of strong heat, especially in the summer. And my physicians have recommended Pedialyte actually. So a lot of my teammates and I know to drink Pedialyte and be extra hydrated on days we have games or practices and intense heat.
That's great. So thinking about electrolyte replacement, but also just even that emphasis on that there should be something special you're doing because these are sort of extreme conditions that you're subjecting yourself to. So this history of repeat summer flu events maybe suggested subchronic dehydration events or a greater susceptibility, something about this child without knowing anything else. Thinking about heat, knowing, just emphasizing that heat exhaustion is a risk that can quickly escalate to something that is severe and ultimately life-threatening if not addressed. And really that importance of post-workout rehydration and recuperation. And then thinking more broadly, if you were in a position as a parent or a clinician to advise a school sports program, how could you prevent heat-related illness and injury? Thinking about it on the team level or on the whole school level. Anyone familiar with sort of heat plans for high schools?
Maybe practices or games could be timed maybe like towards the evening where it's like the sun is going down, or even morning practices so that they aren't
some
exposed to
sports
hot.
teams are starting to adjust the timing of their workouts and their practice and maybe their games, and also just being aware. We'll get into some tools later, but there are tools that help you know. I mean, there's the basic weather forecast, and there's heat alerts, and then there's specific heat index alerts. So making people aware about the risk, the coaches, the trainers, other adults involved in this, in the scheduling of this. Thinking about having on-site staff to monitor and promptly address this, allowing for acclimatization, building that into the schedule and the practice timing. Maybe that means starting earlier, modifying activity as needed if the weather is particularly extreme, for example. And then thinking about each individual child and whether or not they've had a recent illness that would maybe reduce their exercise heat tolerance. If someone has had a vomiting or diarrhea event in the recent past, they are probably still a bit underhydrated and need to have extra caution taken. In that article by Dr. Sinai and others that I mentioned, they gave a specific script. Isabel, will you pretend that you're a physician and read this out to us?
Sure. We are seeing more hot days every year in our area because of climate change, and the heat can be tough for people who exercise outdoors or with breathing problems or who are older. Let's discuss ways to make sure you are prepared and options for getting a break from the heat if needed.
Thanks. So simple, can be short, but it's a way of bringing in climate change and sort of keeping it on our own radar and helping convey that as an important health driver. So the case that we just looked at had a happy outcome, right? That he went on to have his own cross-country career and presumably no ill effects. But there are not happy outcomes that have occurred. This newspaper report from 2019 was 2 Navy recruits who both had sickle cell traits, so an underlying genetic predisposition to be very susceptible to the effects of dehydration. And they both died during their boot camp experience. And so this is something that does not have a lot of research into it. And there are probably other pre-existing susceptibilities. That's why I gave that summer flu example. We don't know that he had something as diagnosable in a sense as sickle cell trait, but these are things that we should hopefully research will emerge about increasing our awareness and ability to counsel on this. So thinking about this clinical management, patients often believe that a lack of symptoms means there's no danger. So that subclinical dehydration that can really set you up for an event often is really within your sort of range of how you feel day to day. Many are unaware of the link between heat and poor health outcomes. It's important to educate patients who fall into any of these groups with higher risk. That includes taking certain medications that predispose them to heat illness, and then helping them understand about acclimatization and the importance of staying in air-conditioned settings during extreme heat events. I mentioned there's some resources. So there's occupational health resources. If you scan that QR code, you can go to the Heat Safety Tool app. There's heat index forecasts through the government weather website. And there's an EPA EJ screener that can help also point people to certain neighborhoods that might have lower air conditioning prevalence, for example, or as Pranav mentioned, lower green spaces that predispose them to have higher heat exposures. We are going, let's see, I think Allie's having a little technical difficulties and she'll be back with us in just a minute. Allie, are you there yet? We'll come back to her in just a second. All right, so she's going to join us. I really appreciate all of these different folks who are joining us today with, as Ali said, many different backgrounds represented. Stephanie, I see the comment from you. In the Southeast, they're working with public health and clinicians as well as athletic coaches, agricultural workers to develop heat safety guidelines and spread awareness of heat-related illness. Yes, and there have been some prominent professional football player related deaths that have led to institutes being founded. The Corey Stringer Institute is one of those that's doing some really great work around helping educate people about the risks of heat. And then now trickling down into non-professional sports teams guidance. And I also saw that MIDA posted the school siting guidelines from EPA. Thank you for doing that. Oh, and Stephanie also put up a good potential partner through NOAA, RESAs, or programs to help populations adapt to climate impact. And you put a link there.
I'm just recalling my own experience with my son many years ago, that thinking that this can happen indoors as well. He was at a baseball camp at our university, and they ran out of fluids, and they were doing some training indoors where apparently the air conditioning was broken, and he ended up with heat stroke. And like, if I weren't a pediatrician, he would have been in the ED. I just rehydrated him at home. But I think probably people think more of outdoor spaces rather than also whatever they're doing, they might be doing indoors. So just throw that out there.
That's a great point. Yeah, if they're not, I think I heard you say the air conditioning was broken there. And right, indoor spaces can get even hotter, as the example that Dr. Salas gave with the patient who had heat stroke. In those indoor settings, and sometimes for just a mechanical malfunction that's temporary, or because of safety concerns about whether or not it's okay to open windows. All of those things can contribute to higher indoor temperatures. Alison, are you back on via your phone?
I am on via my phone, so no, I can't, unfortunately, I can't see the chat or anything,
Okay. Well,
but I'm here.
You in, and I have it on the clinical scenario 3 slide now for you.
Great, thank you. So is there anyone, so this is an adult case, we're sort of moving away from some pediatrics now. Is there anyone who would like to read clinical scenario number 3?
Is Emma available to read it?
Sure, I can read this.
Great.
So this is Mr. Richards. He's a 75-year-old man with cardiovascular disease, diabetes, increased lipids, stable angina, status post a cabbage. And he walks daily up a hill near roadway in the late afternoon, experiences occasional dyspnea and SSCP, and worse when air is hazy for a few days.
Thanks, and sorry about the abbreviations there. That's substernal chest pain. Next slide, please. Yeah, next slide, please. So the question here for discussion is, do we think that his angina is due to progression of heart disease, or potentially are there other contributing factors?
Could be both.
Right, of course. So, clearly somebody with unstable angina needs to, undergo an appropriate medical evaluation. But I do think it's important to note that he states that his symptoms are perhaps worse after a few hazy days, therefore suggesting perhaps that that air pollution or other exposures may be playing a role. We know, especially from our discussions regarding the first case, that air pollution is generally worse near roadways, and excuse me, that there are acute effects of both ozone and PM 2.5 exposure on cardiovascular effects. For example, we know that acute exposures can lead to increases in blood pressure, can affect endothelial function, etc. And therefore, it would be important to think about air pollution exposures as a potential exacerbating factor. Next slide. And so leading from this, are there any recommendations that we can think of that would be appropriate for this patient?
This is Emma again. Again, I'm still a student, but what jumps to mind for me is having him be mindful of the air quality on the days he's walking up that hill. And if it's been hazy for a few days, or if the air quality looks particularly poor, maybe consider driving or public transport.
That's a great point. Thank you. And so I think that there's probably a couple ways to approach this. The first is that clearly, his physician or healthcare team have done a good job on educating him on the importance of exercise in terms of reducing cardiovascular risk. And so I think it's, the first step would be that it's important to congratulate him on this and his efforts to improve his risk factors by exercising. But then really stress perhaps the importance of modifying that regimen so that he is walking and avoiding roadways. So if there are any nearby parks or other green spaces. And as you mentioned, to educate him about resources that are available to empower him to monitor air quality so that he can perhaps on those days when air quality is poor, choose to do exercises indoors or essentially modify his regimen. And next slide.
Well, we've come a long way since the 1950s when episodes like this London fog event that occurred as featured in an episode of The Crown, where the air pollution was so bad, the cars couldn't move around safely. We have come a long way from that. Just because you can't see it doesn't mean it doesn't have health effects. And so there is this air quality index that's been developed and is available through some apps and through the airnow.gov website that can help you know what the air quality where you are in the United States is, and then consequently help advise patients or loved ones, particularly those with pre-existing conditions. And it can give you that daily localized air quality that you need to be able to make those decisions on whether or not that's altering sports teams practice or your own individual. And then I also wanted to point this resource that we've developed through the New York State Children's Environmental Health Center network called Prescriptions for Prevention. There's the QR code there if you want to scan it, or go to nicecheck.org to find. We have this and a whole host of other old-timey style prescriptions that clinicians can use with simple messages and then resources. And many of these have been tailored for local resources when that's applicable.
And we're coming to a close here, but just another
resource available is through the Million Hearts campaign. And this is a nice website that explains in plain language what the risks are so that patients can take steps to protect themselves. They also on the website have posters and pamphlets that can be printed for your office. And actually a really nice review of recent and important studies that address the relationships between air pollution exposure and heart health. Next slide. Specific AHA poor air quality recommendations include things that we spoke about, avoiding unnecessary exposures, avoiding travel to highly polluted regions, avoiding outdoor activities at highly polluted times, for example, during rush hour, using air conditioning and closing your windows to reduce indoor exposures. And if you are sending patients indoors, again, during times of elevated outdoor exposures, advising those patients on how to improve indoor air quality as well.
We thank you all for your participation today. We know we're at time, and we want you to be able to get back to see the poster presentations through the web casting. But thanks again, and I hope that this was helpful for you all.